Hi, welcome to Care is Everywhere, where compassion meets conversation. I'm your host, Anthony Brown, aka the Ghetto Practitioner. Yes, I'm a real nurse practitioner and actually a mental health advocate, and my heart is to the homeless people. Today, we are talking about something that affects every community: addiction, mental health, and homelessness. These challenges often overlap, and behind each one is a person with a story worth hearing. Joining me is someone who spent his career helping people recover and rebuild, Dr. Drew Pinsky. You know him from Loveline, Celebrity Rehab, and his decades of work in addiction and medicine. Dr. Drew, is an honor to have you here.
Anthony, as you know, when you call, I come, and I'm happy to do so, my friend.
Well, thank you. I appreciate that. I just want to dive right in there. I just want to pick your brain and get.
Yeah. I would love this. You go whatever you interest me. Let's do it.
Okay. You said before, or heard before, that addiction isn't a moral issue. It's a medical one. That's a huge shift from people who grew up hearing the opposite. Can you explain what's actually happening in the brain when someone becomes addicted?
Right. So, I guess people we have to go all the way back, Anthony. So people get this weird. So people get so angry with drug addicts. They want to make it their responsibility. They want to make it a moral failing. But look, nobody would choose to get stuck using substances that destroy their life and then having to keep using them in spite of those dire consequences. That tells you something is going on in the brain. And that's, in fact, what we know. And then people get all very bent out of shape about is something or is it a disease? So let's just start with that, okay?
Okay.
These model of addictions, what we're talking about here. Brains get sick, just like other organs get sick, everybody. Just because it's where you think and feel doesn't mean it can't get sick. It does. And dementia is not the only thing that can happen to it. All kinds of things can happen to the brain, and addiction is one of those things. The brain is ultimately has two kind of motivational systems within it. It has a wanting system and a liking system. Two very powerful systems that get you to survive. Those are your survival system. You have to want to do something, and then when you do it, you like it, so you want to do it more. But then in the case of addiction, the wanting takes over. Even when you don't like it anymore, and you certainly don't like what's happening in your life, the wanting is overwhelming. And the other thing the wanting does that makes it so pernicious is it takes over all the other systems in the brain. So you start thinking things are good ideas, or thinking that things are a certain way or ought to be a certain, whatever. We call it stinking thinking. The thinking gets taken over by all this wanting. And so you're not even, as an addict, you're not even aware necessarily you want it. You're just aware that your brain goes, hey, you should talk to Joe. I just talked to Joe. You haven't seen that guy in a long time. Well, who's Joe? Well, Joe's the guy I used to crack with. So, I didn't think about that. I just wanted to talk to Joe. But your brain thought about it, and it's getting you closer to relapse all the time. And that's why I love your story, Anthony, because it shows so many of those lovely thinking. I love one of the things I like about working with addicts is that the thinking is freaking comical. It's hysterical when people get through it and look back at the distortions of thinking. It's funny. And I know I've given you crap about your thinking for a long time, so you can tell your story if you want, but I like that part of your story.
Yeah, my story is, it's the insanity part of the disease, doing the same thing over and over, expecting a different result. Here I am thinking that, okay, I go and I'm going to hang out on a certain block on a corner and try to distribute drugs and get busted. And it's like, okay, I'll go to jail, come back to the same spot. But my best thinking is, well, I'm going to just try to hide it differently, you know? And even when I got enhanced thinking, it's like, okay, how about this? How about if I just go one block south from where I was, and I still end up getting arrested? So yeah, there is definitely some insane.
But you said you always tell your story though. When you tell your story, you talk about sitting in jail, going, "What is wrong? Something's really wrong here? Oh, I know. I should put it in my socks." Right. It's like your awareness. You're aware that something's wrong, but the distorted thinking kicks in. It's so funny.
Yeah, it is definitely that, and I can remember that I actually gave that some deep thought. I I spent months in jail crafting that new plan, you know. And the best thing, and I couldn't go back to jail. It's insane.
I love it. All right, so let me go back to the disease concept.
Okay.
Literally 100% of people that I've spoken to that have a strong opinion about whether addiction is or is not disease cannot give me a definition of disease. You cannot know something is or is not something unless you have an inclusive, very clear definition of what it is before you know what it isn't. So what is a disease? So a disease is a complex relationship between the genetics of the individual and the environment. This is all disease. This is not just addiction. All disease is a gene-environment interaction that results in an abnormal state of physiology or biochemistry. We call that pathophysiology. And people like Anthony and I see signs and symptoms that tell us that pathophysiology is present. And those signs and symptoms will follow a predictable pattern. We call that a natural history. And then guys like me and Anthony try to change that natural history in a positive way. We call that treatment. The natural history, the treatment may be nominal because it may resolve on its own, or the treatment may be lifelong because the natural history of your illness is it becomes chronic. And now we have a chronic natural history. In the case of addiction, we know the genes. We have multiple gene candidates. We know the environmental triggers, the most powerful ones being childhood trauma. We certainly know where the pathophysiology is in the brain. It's in the medial forebrain bundle. It's the firing of the ventral tegmental cells into the shell of the nucleus accumbens. And we actually know within the cytoplasm of the cells in the nucleus accumbens that these second messengers change the genetics of those cells. It's called cyclic AMP response element binding protein. And those cells now are responding differently to input from the rest of the brain through the medial forebrain, and they're forever changed. And some of the change is creating constant drive. Now, that drive can settle down with time, but that drive gets re-triggered under exposure to the drug again. That's the basic physiology. There's many other phases to it. I mean, there's all kinds of, you injure your brain doing certain drugs, and as the disease goes along, your frontal lobes tend to downregulate, and their problem-solving skills get screwed up. There's a famous sort of, I forget the name of this experiment. It's a neurological experiment where it's a card game where you have to sort of adjust to win the game, and addicts never adjust. They just don't adjust. They just keep doing the same thing over and over again, and when you ask them why they don't adjust, they just say, "Well, I just figure my life's going to change. It can't keep going like this. It's eventually I'm gonna get a winner," as opposed to changing and that's a brain thing. That's a biological problem. And then, of course, the withdrawal and dependency, which is a different thing. Withdrawal, dependency, craving. I've not mentioned craving yet. That's a different thing. These are all different phenomena. So with certain drugs, you get tolerant to it. You need more to get the effect. And if you try to stop, you get withdrawal. Opiates and alcohol being sort of the paradigms for that. By the same token, some drugs cause craving in some people. And there's this wild preoccupation in my field, addiction medicine, with craving. I have always felt that craving was a good thing. Now, obviously, if the craving is so severe that it makes you desperate, people don't measure desperation. The feeling of desperation is the numero uno reason people leave treatment. They're just like, I gotta go, desperate. They don't even have craving necessarily. They just feel desperate. Craving, people that don't have craving when they're early in recovery, guess what would you imagine somebody who doesn't have any craving does, say, after their first treatment? Anthony, what happens with their treatment?
They don't have a problem.
They don't have a problem. They don't have to go to treatment anymore. They don't, no big deal. I don't want this shit anymore. That's it. I'm done. Yeah. So in my world, craving is a good thing. You craving, that's your disease letting you know it's on. It's on. So get your butt to a meeting, take the cotton out of your ears and put it in your mouth and sit down and shut up and listen. And just keep doing that. And the odd thing about addiction is people get so used to being in survival mode and being outside of society, it's hard for them to take direction. But if addicts would just take direction, they would literally all get better. They would all get better. But of course, the disease doesn't want them to get better. And that's the pernicious part.
Yeah, and it's, speaking from the seat of an addict, because once an addict, always an addict. There ain't no candy coat now. I know, and it's really interesting because it seems like it's an ongoing process. I mean, if I don't get up and check myself, then I get uncomfortable by some oddball trigger, or my shoestrings untied, or she didn't call me today, so I feel bad, and all of that other crap.
Well, but see, your disease is sitting there outside of your consciousness going, yeah, that's right, Anthony. That is crap. It is unfair. You could feel better. I know what to do for you. It's like that's a fun. Yeah, you feel so much better, man. Of course, you owe that to yourself. You're right. That's addiction talking to yourself.
And so that's bananas. And so knowing all of this happens in the brain, as complex as you explained it, which is great. What's the solution? I mean, I know Ashton is
we haven't defined addiction yet, so I got to define that first.
Well, then let's.
So I was very broad, and you as a nurse practitioner know that you have to use all these categories and subcategories and substance use disorders, this and that. Right. The whole substance use, the SUD disorder, was something invented by SAMHSA, the Substance Abuse and Mental Health Services Association, because addicts were feeling stigmatized. They were stigmatized by being called addict. I've never, ever met a drug addict who minded being called an addict or felt anything like stigma. My patients were interested in one thing, either getting drugs or getting better. That's it. They didn't care about anything else. They were surviving. Stigma families worry about, and they need to stop it. It's not a disease that should have stigma. I feel like we built the stigma more by building a whole nomenclature around it. But okay, here we are: substance use disorder, intermittent, severe, blah blah blah. Fine, it's a way of parsing it out a little more accurately. I'm okay with it. But I still have a broad definition of addiction. So here's addiction.
Okay.
It is a genetic disorder with a biological basis. The hallmark is progressive use and preoccupation in the face of consequence. Consequence particularly work or school, finance, health, legal, or what I leave out, relationships. Those 5 areas of your life are affected, and yet you keep using, and grandpa was an alcoholic. Well, that's it. That's the disease. That's it. And there's one other feature that is actually defining that this must have been 1992 article in JAMA threw in there was denial. There has to be denial. And denial is a very complicated process. It is not lying. It is not one thing. It's a lot of stuff, including things like, I was blacked out and I don't remember, and therefore it didn't happen. So all kinds of things like that. So there you are. That's the disease of addiction.
Fascinating. I'm mesmerized when you share this kind of level of knowledge. Again, I'm the ghetto practitioner, which means I'm still not good at all of this stuff, but I'm eager to learn, and I'm thirsty for knowledge. And the way you lay it out there, definitely, I'm going to be doing a bunch of homework tonight. Thank you.
You don't have to. You just listen, because you know this. You know it. That's why it resonates with you. And I've worked in addiction field for 40 years, and I have seen so many bad ideas come and go, and we got lots of bad ideas right now. And so you said, what do we do about it? Yeah. Well, there are not enough professionals on earth to do for addicts what they need to get well. Many times early in their disease, they need 24-hour, 24/7 availability of somebody to sit on them or talk to them or structure their world or get them into a fellowship. It's constant early on. And what John Kelly has shown, he's the director of the Harvard Addiction Program, is that mutual aid societies, we can't even say 12-step because people get all weirded out if you say 12-step, but you and I know that's what I'm talking about. Mutual aid societies, in a careful Cochrane analysis, do better or as good as any professionally managed service. And they're available all the time, and they're free. And why we would get in the way of free medical services that work is disgusting. It works. Avail yourself. I've seen the miracle of tens of thousands of times. And generally any addict that gets well, not 100%, but 90% or certainly 85% get well. They end up in 12-step program of some type because they need it and it works. So all right, I'll leave it at that. I've got obviously lots more to say, but the reason I'm synthesizing 40 years of experience here, and science, I remember, I got another good one for you. You'll like this one. So back when the genetic piece was getting worked out in the early 90s, and there've been many candidate genes isolated since. I was actually at an addiction meeting where somebody went, we could maybe test in utero for this gene and maybe abort babies with addiction and get rid of this illness. And I was like, oh my God, that what a freaking moral leap of logic where you're going. First of all, who knows? I'll tell you, you'll be taking something out of the human genome that has evolved over millions of years for a reason. And you're talking about eliminating my patients, people I care about very dearly, who carry this side effect of their genetics. And then I started thinking, these genes must have significant benefits also. And because I got angry with these people talking about this, and I was like, there's got to be good genes here. And I started thinking about it, because there's no way that this gene would persist so consistently in the human genome without there being some benefits. So people think about evolution as being, evolving in a better direction. That's not how we evolve. We evolve in, stops and starts and forwards and backwards. And when we move forward, there can be things that come with those genes that are not great in certain circumstances for which the gene had not evolved, right? For instance, sickle cell, right? Sickle cell evolved to resist malaria in Africa. Well, when you don't have malaria around, sickle cell is only a bad thing. But that's the kind of genetics I'm talking about here with addiction. So right at that time, the movie Braveheart came out. And I'm watching it, and I'm like, wow, 10,000 Scotsmen going to battle. And the 10 guys that survive, clearly alcoholics. They portray it that way in the film. And I thought, well, that's interesting. And I don't know if they did it consciously, but they certainly portrayed it that way. And I thought, yeah, if you look at populations that are isolated, right? Isolated by geographic isolation for multiple generations, and during those generations, there's some side of genocidal assault repeatedly, that's where you see the gene come up. So literally, another way of saying that is alcoholic addicts are better survivors in extreme adversity. And guess what? You guys make great fighter pilots, great extreme athletes, great shortstops, and most patients will tell me, when you're in that, doing that 720 in the loop, what happens? Time slows down. I'm not anxious in that moment. I can see everything. It's like it's in slow motion. That's why the shortstop is so good. I can check home plate. I can see what the pitches do. I can throw it to first. And they make wonderful, it's part of this genetics. And so I started amusing myself by going into I would give lectures every week to my patients. And I started amusing myself I thought to myself, well, what would happen if something really intense happened here? I go, what would you guys do if a bunch of Huns with spears came over the parking lot here? And 90% of them go, I grab something. I go out there. I go at him. I'm thinking, oh, that's not what the codependents do at all. That is not normal. Or what I go, I would revise it over the years. Well, how about if a bomb went off in the parking lot? What are you guys going to do? I'll go check it out. You got to go out there and check it out. It's like, and evidently in those extreme environments where you can keep your wits about you and you fight, you're more likely to survive, evidently. So you feel good about this, which is why this is all a long way of saying stigma has no place in this condition. It makes people do bad things, I understand, but the disease itself should not be stigmatized.
And it's fascinating how you pointed that out, because, when we went through COVID, I managed the mental health hospital through COVID. And while everybody else is running around going, oh my God, I'm like, hey, let's just do this and let's do that. And I go, what's wrong with you? Like, there's stuff me.
They're absolutely at their best. They're who you want in the cockpit with you, for sure. They are at their best. And again, this, it's a genetic liability when you start finding powerful chemicals, and it's an asset when you're in extreme circumstance.
Very fascinating. Well, now I feel special, Dr. Drew.
Good. You should deserve it.
And so, I know back in 2005 or something, when I was really working in specifically treatment, they came out with Suboxone, and that was when we first had it, it was just for opiate taper and detox. What's your views on the way that's being used today?
Let's just say I'm sort of crestfallen, because literally I had a doctor who claimed to be an addiction medicine specialist tell me that there was no such thing as an opiate addict who could recover in abstinence, which I shared that with all of my recovered abstinent opiate addict colleagues and friends, to which they responded, I wish she was around when I was trying to get sober, because she would have given me Suboxone, and I guarantee you I would still be on Suboxone or I would be dead. And Suboxone is a powerful opiate. Now, it's different. It's a mu agonist. I get it. A kappa agonist. And it has utility. I'm not saying everything has utility. The problems start when people just apply it everywhere in all cases. That's how doctors get into trouble. Opiate, you have to find the right patient for the right treatment. So let me explain what Suboxone is. It's a considered a medically assisted treatment. It's a replacement therapy for opiate addiction. It's a way to make opiate withdrawal easier. And by the way, when Suboxone came along, this was like in the 90s and the early 2000s, here's some words that never came out of my mouth, ever. How am I ever going to get an opiate addict off of opiates? What are we going to do with these people? We had no problem. We had protocols. We had ways of dealing with their withdrawal syndromes. We had no problem. 3 days of flu-like, kind of miserable. We got them through it. Done. The Suboxone, now you're in a week. Now it takes a while. Now it's tapered. And you still have withdrawal at the end of that taper.
Right.
And guess what happens? People go, oh, you just stay on the Suboxone. It's no big deal. It's no problem. That's still massaging that part of the brain at certain doses. At very low doses, I'm not sure that's true. And for some people, if they need to stay on 1 or 2 milligrams, I'm no big deal with that. If people are on 4, 8, 32, I got a problem. That's somebody waiting for a relapse. That's in relapse. So their thinking is going to be off. They can't do treatment. They can't do the emotional work that's necessary to recover. They can't do the interpersonal work. They can't be of service. They can't do the work. So I have grave concerns about the excessive utilization of Suboxone, the excessive dosing of Suboxone. Save one situation: chronic pain and addiction. That is a challenging situation. It is a specific patient group, and they benefit greatly from Suboxone. And strangely, I cannot explain why, unless it's addict stuff, I don't know, the doctors and the patients resist using it. It's the weirdest thing I've ever seen, because it works like crazy, but they just resist it. Like, when you say this should be a first-line drug for chronic pain. Oh, blah, 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 blah. I'm just telling you, I'm only saying it because it works. It restore your life. And so it's weird. But generally, I will just, my bias obviously is I did not allow Suboxone on my unit. I did not allow benzodiazepines. I did not allow Suboxone. Not because I felt specifically that there was no utility to either of these medicines. There's utility to everything, in certain circumstances. You got to have a toolkit to help patients. But if I had either of those patients on the unit, either of those substances on my drug unit, I had a 25-bed unit, and somebody was given one of those medicines, I could no longer run the unit. Anthony, tell me why that would be. I could no longer run these. Somebody's given Suboxone. Why all of a sudden does the unit, everything falls apart on the unit? What happens?
I'm gonna manipulate the heck out of you because I want what I want.
Well, no, because he got it and I didn't.
Yeah.
Now I'm coming after you. The unit starts vibrating. It's unbelievable. People fight. It's a non-manageable situation. So I just made a arbitrary decision. These substances cannot be in my unit. If you want them or you're a good candidate for them, you got to go to the psych unit. Go ahead and get them. I'm not. Find if a doctor wants to do that for you, I'm not objecting. I just can't run a drug unit with that shit on the unit. The other patients just fall apart. They can't do the work early in recovery. Men, your mind, their brains are on fire.
Yeah, it's crazy because I get I don't have a bias against it. I'm just because maybe I do because I'm an addict and I know what it does. And I remember the old fashioned way. We give you a little Clonidine for your blood pressure. We give you Robaxin for your muscle aches and a little bit of benzo for your anxiety. And after that, it's like go to great.
You know why? You know why I did use the benzos? I used a lot of the back pain and leg pain was actually restless leg. So I used a lot of what's it called? Mirapex. A lot of Mirapex, and if somebody was agitated, what did I used to use? But I'm just saying this because I always found that benzos made them worse. Benzos made them climb the mall more. I think it kind of triggered craving or desperation or something. So I used to use it and then I stopped. What did I use? Man, it's been a while since I ran a unit. But anyway, we never had any problem. Everyone was very comfortable. No big deal. Everyone was fine.
Yeah, it's fascinating. And back in the day when I used to detox, I mean, I wasn't much of an opiate. I was more of an upper kind of person. But they throw me in jail, and I see everybody else just shaking the bacon, and you didn't die. It's like, okay, tough it up, and there you go. But that's just the way it used to be. Things have changed so much, and again, we want everything when we want it, with no commercial interruptions and all that other happiness. But yeah, it's fascinating that we get to study and we get to know more about addiction opposed to where it was just a guessing game. And again, like you said, it came with a whole bunch of stigmas. And now we have scientific fact to prove what works, what doesn't work, what's causing it, and all of that stuff. And so I know your time is precious. I appreciate that you come in here with us, Dr. Drew. Tell me, of course, I have a bazillion questions.
I got 10 more minutes. I was late. We started late by fault, so you get extra bonus time.
Okay, great, love it. Okay, and so, do you agree or disagree that detoxing has to go, or substance use or substance treatment has to go hand in hand with some sort of intensive therapy, or just what's your
So this is a really interesting and complicated landscape, right? So I just arbitrarily in my own thinking, I divide what you're talking about into sort of two categories: recovery and something I call complete or total recovery, right? Some people are just going to recover, and that's good. They're not doing drugs, they're in recovery, but they still have a lot of stuff going on, and they might want to work on that stuff, because if you do, then we have a complete or total recovery on our hands here. So the kinds of stuff we're typically talking about are trauma, right? Both trauma from childhood, which is the rocket fuel of addiction, and trauma from all the shit you did in your disease. There are always interpersonal issues, attachment issues that need to get sorted out. So, attachment focused, trauma informed, EMDR, all this stuff, neurobiofeedback, tremendously effective and helpful. Now, the question becomes when, right? A lot of this stuff, if you start doing it early, makes things worse for the patient. So you want to do this. It takes a lot of skill, and I would say there's no sort of template for it. I mean, there is a template. The template is generally, I like people to focus on their sobriety for about 6 months, mostly because you remember anything that happens the first 3 months. Your brain is so messed up that you literally won't remember anything. And so to do these very complicated interpersonal interventions in the first 3 months literally makes no sense to me. Now, neurobiofeedback, stuff like that, building regulation stuff, okay, that can be helpful. But much more than that, just do the program, because the program's got a lot of stuff built into it, as you know, already. And those features magically, and were developed in a empiric fashion, it was multiple people sharing ideas that came together that made the big book. It was clergy, it was doctors, it was social workers. And when they shared their ideas about what helped alcoholics, originally designed for alcoholism, same biology, same part of the brain, same everything, just different trigger chemically, they put together this thing called the 12 step. And man, does it work. And a lot of people don't find they need much after that. If they really do the hard part is early in your disease, you don't really know whether you're all the way in or not. Your brain tells you you're in, and your thinking may be messed up still. You may not would be aware of certain stuff. That's what leads to relapse, right? There's a dirty secret in addiction medicine. For a severe alcoholic, it takes on average 4 treatments in 5 years to achieve 1 year of sobriety. So that's John Kelly's data again. My opinion is if you stay with it long enough, if you stay with it, you'll get well. But you have to stay with it. And then somewhere along the way, the underlying psychological, psychiatric, and by the way, early on, because of what the drugs do to your brain, it's quite appropriate to be on mood stabilizers. Things like Depakote and Neurontin can be very helpful for the 6 months of treatment, both for post-acute withdrawal, your brain is still in kind of a low-grade withdrawal state, and for the injury of the drug. So using pharmacotherapy early in treatment can be very, very, very helpful. It's just the worst thing in the world that an addict can start to think is another liability to too much treatment too early is, yes, it's because my mom hit me with that sword. That's why I'm a drug addict. If I just do the EMDR, I'm going to be fine. And that's your disease talking. Your disease always wants everything to be fine so it can reassert itself. So you can find it. That's why people go, I had patients that would do years of psychoanalysis. And when I would look at what they were doing, and I like psychoanalysis, I think it's a really interesting field, but I would look at what they were doing and they were always doing the same thing, which how can I figure out how to deal with all this shit I've got so I can keep drinking? That's always why they're in analysis. How can I become a good drinker? Which it's not possible. It's the way this disease works. It's just not possible. You could go ahead and try it. It will ramp back up again. It ramps up usually rather quickly. You may control for a while. It will come back. So yeah, I'm a big fan of various interventions later in the game. 6 months, certainly people should start looking at these things. EMDR, I'm a huge fan of EMDR in later in treatment with drug addicts. I refer all the time to a variety of different practitioners. Some people need more CBT. Some people need more interpersonal neurobiology. Some people need more motivational. I mean, there's different needs that, for different patients. There's different things we can do, right? Which is the great news about this. But to do too much too soon is a waste of money. And if anything, just motivates you to think you're well, which you're not. And there's so much to be gotten from 12-step, which I'm finding myself. So I have, family members with addiction who are in 12-step programs, and I'm now watching it, in real time, close at hand, the miracle of recovery, and it's phenomenal. And in spite of, I'm laughing because my staff has told me we're recording here on a Thursday. They've told me for 30 years I need to go to Al-Anon. And so I'm finally going and doing work and doing the steps myself, and it has been fantastic. And I see now, as of now, not just seeing my families recover, but also as my own personal engagement with 12-step. And I've had lots of psychotherapy and lots of trauma therapy and stuff. I wasn't fixed fully either. I see the place. I see how it works with the therapy now, which is something I did not fully appreciate.
Well, that's cool, and it's fascinating because they do say addiction is a family disease. I mean, it touches all over the place.
Yeah, and if you're I've said for a million years to patients, they come in the patient's family. They always it's the same conversation. This is one of the reasons I finally got my own shit together. I knew I had to do it. Families come in and go, I'll do anything for my son. I'll do anything. Tell me what to do. I'll do it. I go, okay, are you listening? There's one thing you can do. I'm going to tell you to do one thing. And this is not a recommendation like, hey, you need to lose a couple pounds and exercise a little more. This is a recommendation that if you do not do, You are a part of the problem. You are contributing element to the problem. You'll do anything for your son, right? Yes? Okay. Here's what I want you to do. And by the way, there's no excuses anymore because everything's available on Zoom.
Right.
So I want you to go to a Al-Anon meeting, get a sponsor, and work the steps. And they always say the same thing. Okay, but what do I do? Like, okay, that's what you do. You go, you get a sponsor, work the steps. And that's it. And that's your one job. And that you will change the way you dance with the addict in the program. Now, the reality is you shouldn't be going for the addict. You should be going for yourself. But of course, co's won't do that. Co's have to do it for somebody else. We just won't do it. Oh my God, I'm so codependent. It's unbelievable.
Yeah.
Anyway, here we are.
It's fascinating because I've made that recommendations to a bunch of people, and I hear all kinds of excuses, and I've been explaining to them, it's like, well, you can just go online, or I had one person say, well, I went to one meeting, I didn't like it. It's like, well, go to another.
Go to another one. And the one feature that people really resist, and it's the really important part, which is the sponsor and the steps, right? That's the part you must do. I don't care. So the meeting attendants are more or less meaningful for certain people on the codependency side. On the addiction side, you got to go. Sorry, you just got to go. You need that fellowship. You need the reminders. You got to go. The codes, it's a little less clear that they have to go with that kind of rigor. And the meetings are all very different. There's all kinds of different stuff out there, and you got to find the one that works for you, number one. But did we lose your connection for a second? There we go.
No,
you got to find the one that works for you, but there's no compromise on get the sponsor, work the steps. I'm sorry, you just have to do that part.
Get a sponsor and work the steps. You heard it straight from Dr. Drew. Get a sponsor and work the steps. Fascinating.
And then I'm walking the walk now too. I'm doing it myself. This is wonderful. It's really been a cool thing, and I've enjoyed it. I've been I don't know. I've enjoyed it. It's been a good thing for me. Yeah.
Okay. I've been in the program for 26 years. Best thing ever. And I didn't grasp onto the program until I was just extremely desperate. And probably the same thing when, people enter Al-Anon. It's like, okay, what else do I do?
Yeah.
And I like the 3 C's. I didn't cause it, I can't cure it, and I can't control it. It's just,
yep.
That's the way it is. And
but the codes, I've learned a lot about the various manifestations of codependency. I kind of thought it was one thing, but there's so many different flavors of it. And in my particular flavor, denial was operating at a level I didn't perceive. And that was my thing. And other people have other things, they got to fix, and they got to save, and they got to rescue. And I was certainly on my version of that. But the denial thing, I was like, wow, I didn't even know that was operating. And you start to see that stuff with the recovery.
Wow. That is, now you heard it here, folks. Confessions from Dr. Drew.
Hey, relax there. Don't promote it as confessions. Promote it as walking the walk.
Okay. So I'm gonna edit that out. But no, it's cool because a lot of times people forget that deep down inside, every one of us are a human being.
Oh yeah. And I get the resistance to things like mutual aid because it seems too. Listen, when I started working I got into addiction treatment by accident. I did not go into medicine. I was going to be a cardiologist, and I started working in psych hospital and got very fascinated with all this stuff. And one of the things I got very good at early was drug detox. Like I said, I would get people off drugs, no problem. And I had nurses that were just, you got to have a great skilled nurse to help with that too. And you got a doctor knows what they're doing, understands what addiction is, and a nurse that knows how to help and administer and work with you. It's just, you get anybody off anything. But early on, I used to sit in the nursing station. I like the culture on drug units, like the people. It was different than the psychiatric part. So I would hang out there, right? And I'm a codependent, right? Early on. And I would look through the window into the treatment room. There was a window where you could watch treatment from the nursing station. And of course, on the wall were the 12 steps. And I would think to myself, I might have probably said it out loud. What is that? That's so dumb. What is that stuff? What is that goofy stuff? I'm getting people off drugs. I'm doing the medicine. I get them off. And then I saw some people recover. Some people who were dying become better than they ever knew they could be. And I was like, oh my God, what was that? What is happening? I want to understand what that is. And that's where I became open to the treat, digging deep into the treatment process and getting a board certification and training and all that stuff to be able to do it.
Yeah. And so,
unfortunately, by the way, let me back to the Suboxone thing. There are very, 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 very few doctors in this country anymore that know what addiction actually is and know what recovery actually is. It's not common. You have to be very, very careful. You have to have been around it for years. You have to see it in all its flavors over and over and over again. And you can't just be handing out Suboxone or medicines. It's a different thing. You have to understand it deeply and how it affects people biologically, spiritually, interpersonally, cognitively, and you have to learn how to see through all that to get out what the patient needs. And that's a skill. That's hard. That's a highly intuitive thing. And I've gotten to the point where I just trust whatever comes out of my mouth when I'm working with an addict, because I know whatever's coming at me is a bunch of BS. And so I just learned to just whatever coming out of my mouth is truth. I just know it. I know it's going to come. And it's because it comes somewhere out of my gut, not up here where I'm listening to you. And even when I'm feeling you and you're in deep pain and stuff, and I empathize with that pain, you may be using that pain to manipulate me, as you often do. And so I may say something nasty in response to it. And I'll shock myself sometimes. I'm like, oh, geez, I can't believe what I just said. Like, and the addict will usually go, oh my God, how'd you know? What, you saw it? Oh, I don't even know anymore. That's the hard part. The addict doesn't even know when they're manipulating anymore.
yeah, but it's refreshing when we finally hear the truth. I mean, after all the pain and all the turmoil and all the nonsense, finally, because when I first got my first sponsor, he just gave me the business, man. He told me, he called me the whiny little bitch who told me shut the up properly. I'm like, wait a minute, I just did all these years in prison. He's like, I don't give a damn. And I'm like, okay.
Well, I'll tell you what, that has to be delivered with great skill. That's actually a tremendous skill. And you can't be abusive. You can't be just nasty to be nasty. It has to be responding to what that patient needs in that moment.
Right.
And you have to be with the patient, to be right there with them when you say stuff like that. And that's why you listened. You knew it was true.
Oh yeah. Oh, definitely. Definitely. Okay. And so, again, I'm grateful for your time. I could talk to you forever. And
Not like it is.
I know, huh? And so, in closing, do you feel that every addict, no matter how far gone he is, can make it? And if so, what do you have to say to them to get them to even get started?
Okay, so that's a tremendous question. I worry. Okay, perhaps I'm biased again by my experience. 40 years of experience, and here's what I learned in that experience: I can't predict anything. People that I'm convinced are going to do well do poorly. People that I don't give a prayer to get well. So I don't try to predict. But those ones that I really thought were going to die and got well give you faith for everybody. When you see these miracle recoveries, you go, oh my God, if that guy can get recovered, anybody can do it. And the ones that, I thought were going to do okay, just that it's, need more, whatever. And some are sicker than others. My fear is, back to folding in the homeless population, that we have let people get so sick now that their brain injuries and their chronic psychiatric symptomatology is going to be so severe that we have created a huge population of people that are going to be absolutely psychiatrically disabled, neurologically, forget even neuropsychiatrically disabled. I fear that. And that group may not be able to get well. And yet I've seen miracles. So the starting place is, we may have really messed some people up by letting this get so crazy. But I still have hope. I still have faith and hope. And you have to motivate addicts. You have to ask addicts to do something. You have to, here's what they will do if you don't ask them to do something. They will do drugs and die. That's it. Addiction is a fatal illness. It is progressive in all settings and most cases fatal. Don't forget that. And this is left out of the conversations in the homeless population. It is negligent manslaughter to provide drugs to people with this disease, because it maybe even murder, because it is a progressive illness that ends in death no matter how the drugs are administered. Even if I lay you on a gurney and administer them IV, there will be progression. You will do some crazier thinking with time. And I worry about that. I just worry. But there's hope. It is my way of saying there's absolutely hope for everybody. I've seen absolute miracles. And let's not let this get any further downstream, because we are harming people, and we need to do something about it.
Okay. Well, thank you, Dr. Drew, for your kind words and wisdom and your time. And as he says, there's hope for all of us. Let's not let it get too far out of control. And remember, care doesn't belong to one system or one profession. It belongs to all of us. All of us. And so on that note, I'm Anthony Brown, aka the Ghetto Practitioner, and this has been Care is Everywhere. Thank you all, and see you next time.